Cholinergic agonists work to stimulate the parasympathetic nerves, some brain nerve cells, and work at the neuromuscular junction. By preventing the breakdown of acetylcholine, they stimulate the parasympathetic nervous system. Actions include constriction of the pupil, an increase of glandular secretion of enzymes, an increase in peristalsis, and a slowing of the heart rate. It is the opposite of the fight or flight sympathetic stimulation. Indirect acting cholinergics are used to treat two types of disease. Drugs for myasthenia gravis target the acetylcholine receptors, and when acetylcholine is released, the muscles contract. If these receptors are blocked by disease or drugs, muscle activity is decreased. Drugs used to treat myasthenia gravis work to allow more acetylcholine to accumulate at the neuromuscular junction, increasing the likelihood that the receptors will be activated, improving communication between nerves and muscles. This increased action means an increase in muscle strength. There are 3 drugs listed on your chart here that are indirect acting cholinergic drugs that are used to treat Alzheimer's disease. One of these is an NMDA receptor agonist. It is important to note that none of these drugs in either class reverses the degenerative process. The goal of utilization of these drugs is to slow the degenerative process. For moderate to severe Alzheimer's, dinazepril is often prescribed. The dosing comes at bedtime, 5 to 10 milligrams. It's usually started at a lower dose, and the patient is assessed for tolerance. Use with NSAIDs is discouraged because of the increased GI secretions, increased GI mucosal erosion, and the increased risk of GI bleeding. The advantage to this drug is the once-a-day dosing. Rivastigmine is a transdermal patch that works similarly to dinazepril, and it carries also the adverse effect of all the CNS headache, insomnia, fatigue, the GI, nausea, diarrhea, dyspepsia, and the cardiovascular risk. In addition, you may have application reactions or skin breakout under the patch. So on page 558, you will find directions on how to apply a transdermal patch, so please review those because it's important for you to know how to do that. Improvement in cognitive function with any of these drugs may take several weeks, and patients and their family members need to be aware that you won't have an immediate response if you have any response. And the dosage must be titrated up and titrated down in order to discontinue them. They cannot be abruptly stopped. The other drug is in a different class. It is an NMD aspartate antagonist, memantine hydrochloride. Memantine is also used for Alzheimer's, but it works very differently. It binds to the N-methyl-D aspartate receptors and prevents binding of glutamate. And glutamate is an excitatory neurotransmitter, so it enhances cognition from preventing the glutamate from being inactivated. Side effects are going to be very similar: dizziness, fatigue, headache. Urinary frequency is often a problem with this drug, and patients who have seizure disorders, who experience urinary retention from various disease processes, or who have liver impairment and renal impairment should use this drug cautiously. The dosage is given twice a day, and it begins at 5 milligrams and is increased over 4 weeks to 10 milligrams BID. So you'll have 5 in the morning and 5 at night, and then you increase that after 4 weeks to 10 in the morning and 10 at night. And then to discontinue this drug, you also need to titrate it down just like you titrated it up. Cannot be abruptly stopped. The advantage of any of these drugs, due to remembering to take the drug if the individual with Alzheimer's is still managing their own medications, is that dinazepril is only given once a day. And so that would be an advantage if the patient is having any difficulty remembering their sequence of taking medications. Chapter 33 talks about anticholinergic drugs. And anticholinergics block the effects of acetylcholine. So in chapter 32, we enhance the effects, and now we're blocking the effects of acetylcholine. And so they block parasympathetic nervous system action. They're commonly used to decrease GI activity and secretions. And because of their risk for systemic adverse effects, they are less commonly used today than other drug classes. Atropine is the drug prototype in this category. It is typically used to decrease secretions before surgery, can be used for patients with Parkinson's, and it can restore sympathetic heart rate and blood pressure. So if the patient has a symptomatic low heart rate, below 60, their blood pressure is dropped, they're very sick, then atropine can be given to increase the heart rate, increase the blood pressure for a patient who is experiencing symptoms of poor cardiac perfusion. The drug is also used to dilate pupils. Side effects would be in the eye area, blurred vision and increased ocular pressure. It can cause tachycardia, so you can raise the heart rate too much. You can raise the blood pressure too much. Patients with all anticholinergic agents can experience urinary hesitancy and retention. And the antidote is physostigmine, is the antidote to atropine. So you need to monitor these clients for atropine toxicity, which is a sudden onset of bizarre mental or neurological symptoms, and they are dose related. So the higher the dose of atropine, the more likely the patient is to experience atropine toxicity. Patients who should not take an anticholinergic include any patient who has a condition that is exacerbated by blocking the parasympathetic nervous system, such as glaucoma, where you already have increased intraocular pressure, so you don't want to make that worse. Any patient with a GI obstruction or ileus, so they already have a very poorly functioning GI tract, so you don't want to decrease peristalsis even further. Patients with benign prostatic hypertrophy who already have urinary retention and urinary hesitancy, any anticholinergic is going to enhance that problem of urinary hesitancy and retention, etc. The other anticholinergic example that we are using this semester is scopolamine, and it inhibits the mucineric activity of acetylcholine. It is used to decrease vomiting related to motion sickness, to opioid analgesia or general analgesia. So a scopolamine patch can be used as one of those balanced anesthesia medications in order to decrease vomiting after the patient has undergone general anesthesia. It will have the same adverse effects as atropine or any other anticholinergic medication. And if the patient is wearing that patch, we need to watch them carefully for signs of photophobia or blurred vision. Same contraindications and the same concerns as with the other anticholinergic medications. Please remember to look at the applying dermal patch delivery systems information so that you can focus on that safe medication administration of any patient receiving a dermal patch delivery system.